Hello everyone, my name is Wu Chunling. I'm from the Department of Rheumatology and Immunology in the First Hospital of China Medical University. I'm honored to give a talk on RA. Today, we particularly focus on the treatment and prognosis of RA. The amount of clinical disease activity in patients with RA reflects the overall burden of inflammation and influences the treatment decisions. Joint inflammation is the main driver of joint damage and is the most important cause of functional disability in the early stages of disease. It is important to assess clinical disease activity scientifically, so several composite indices have been developed. The ACR 20, 50, and 70 improvement criteria, disease activity score, simplified disease activity index, and clinical disease activity index. The ACR 20, 50, and 70 improvement criteria corresponds to a 20%, 50%, and 70% improvement respectively in joint coins, physician-patient assessment of disease severity, pain scale, levels of acute phase reactance, and a functional assess using a self-administered patient questionnaire. These criteria are commonly used in clinical trials as an endpoint for comparing the proportion of responders between treatment groups. In contrast, the disease activity score, simplified disease activity index, and the clinical disease activity index are continuous measures of disease activity. These scales are used in clinical practice for tracking disease status and treatment response. Several developments during the past 2 decades have changed the therapeutic landscape in RA. The first is MTX is recognized as DMARD of first choice for the treatment of early RA. The second, novel highly efficacious biologicals can be used alone or in combination with MTX, and the combination DMARD regimens are proved to be superior over MTX alone. The medications used for the treatment of RA may be divided into the following categories: NSAIDs, glucocorticoids such as prednisone and methylprednisone, conventional DMARDs, and biologic DMARDs. Although the disease for some patients with RA is managed adequately with a single DMARD, the situation in most cases demands the combination DMARD regimen. The first is NSAIDs. NSAIDs were formerly viewed as the core of all other RA therapy, but they are now considered to be adjunctive therapy for management of symptoms uncontrolled by other measures. NSAIDs exhibit both analgesic and anti-inflammatory properties. The anti-inflammatory effects of NSAIDs derive from their ability to non-selectively inhibit COX-1 and COX-2. Their side effects include gastritis and peptic ulcer disease, as well as impairment of renal function. Due to the possibility of side effects, chronic use of NSAIDs should be minimized. Glucocorticoids may serve in several ways to control disease activity in RA. The first, they may be administered in low to moderate doses to achieve rapid disease control before the onset of fully effective DMARD therapy. The second, a 1 to 2 week burst of glucocorticoids may be prescribed for the management of acute disease flares. The third, chronic administration of low doses may also be warranted to control disease activity in patients with an adequate response to DMARD therapy. Low-dose prednisone therapy has been shown in prospective studies to retard radiographic progression of joint disease. However, the benefits of this approach must be carefully weighed against the risks. The fourth, high-dose glucocorticoids may be necessary for treatment of severe extra-articular manifestations of RA, such as ILD. The fifth, intra-articular injection of an intermediate-acting glucocorticoid may allow for rapid control of inflammation in the setting of a limited number of affected joints. DMARDs are so named because of their ability to slow or prevent structural progression of RA. They include conventional DMARDs, biologic DMARDs, and synthetic DMARDs. The conventional DMARDs include HCQ, SSZ, MTX, and influnomide. They exhibit a delayed onset of action of approximately 6 to 12 weeks. Although similar to the other DMARDs in its slow onset of action, HCQ has not been shown to delay radiographic progression of disease. In clinical practice, it is generally used for treatment of early male disease or as adjunctive therapy in combination with other DMARDs. SSZ is used in a similar manner and has been shown in randomized controlled trials to reduce radiographic progression of disease. MTX is the DMARD of choice for the treatment of RA and is the anchor drug for most combination therapies. As the doses used for the treatment of RA, it has been shown to stimulate adenosine release from cells, producing an anti-inflammatory effect. Influnomide is an inhibitor of pyrimidine synthesis. The clinical efficacy of it appears similar to that of MTX. It has been shown in well-designed trials to be effective for the treatment of RA as monotherapy or in combination with MTX and other DMARDs. Biologic DMARDs have revolutionized the treatment of RA over the past decades. They are protein therapeutic designed mostly to target cytokines and cell surface molecules. The TNF inhibitors were the first biologicals approved for the treatment of RA. Currently, 5 agents can be used. There are 3 different anti-TNF monoclonal antibodies. Infliximab is a chimeric monoclonal antibody, whereas the adalimumab and golimumab are humanized monoclonal antibody. Certolizumab PEG is a pegylated Fc-free fragment of a humanized monoclonal antibody with binding specificity for TNF-alpha. Lastly, etanercept is a soluble fusion protein comprising the TNF receptor 2 in covalent linkage with the Fc portion of IgG1. All of the TNF inhibitors have been shown in randomized controlled clinical trials to reduce the signs and symptoms of RA, slow radiographic progression of joint damage, and improve physical function and quality of life. They are typically used in a combination with background MTX therapy. This combination regimen affords maximal benefit in many cases and is often the next step for treatment of patients with an inadequate response to MTX therapy. Anti-TNF agents should be avoided in patients with active infection or a history of hypersensitivity to these agents and are contraindicated in patients with chronic hepatitis B infection or class 3 or 4 congestive heart failure. The major concern is the increased risk for infection, including serious bacterial infections, opportunistic fungal infection, and the reactivation of latent tuberculosis. For this reason, all patients are screened for latent tuberculosis according to national guidelines prior to starting anti-TNF therapy. Abatacept is a soluble fusion protein consisting of the extracellular domain of human CTLA4 linked to the modified portion of human IgG. It inhibits the co-stimulation of T cells and may also inhibit the function of APC by reverse signaling through CD80 and CD86. It has been shown in clinical trials to reduce disease activity, slow radiographic progression of damage, and improve functional disability. Many patients receive abatacept in combination with MTX or another DMARD, such as leflunomide. Abatacept therapy has been associated with an increased risk of infection. Anakinra is a L1 receptor antagonist. Its benefits have proved to be relatively modest compared with the other biologicals, and is rarely used for the treatment of RA with the availability of other more effective agents. Anakinra shouldn't be combined with an anti-TNF drug because high rate of serious infections have been observed with this regimen in clinical trials. Rituximab is a chimeric monoclonal antibody directed against CD20, a cell surface molecule expressed by most mature B cells. It works by depleting B cells, which in turn leads to a reduction in the inflammatory response by unknown mechanisms. These mechanisms may include a reduction of autoantibody inhibition of T cell activation and alteration of cytokine production. It has been approved for the treatment of refractory RA in combination with MTX and has been shown to be more effective for patients with seropositive than seronegative disease. It is associated with mild to moderate infusion reactions as well as an increased risk of infection. Tocilizumab is a humanized monoclonal antibody directed against the membrane and soluble forms of IL-6 receptor. It can effectively control the joint inflammation and damage by inhibiting intracellular signaling pathways that affect the acute phase response, cytokine production, and osteoclast activation. Clinical trials attested to the efficacy of tocilizumab therapy for RA, both as monotherapy and in combination with MTX and other DMARDs. It is also associated with an increased risk of infection, neutropenia, and thrombocytopenia. However, the hematologic abnormalities appear to be reversible upon stopping the drug. In addition, this agent has been shown to increase LDL cholesterol. Because some patients don't adequately respond to conventional or biological DMARDs, sensitive DMARDs has been investigated to fill this gap. They aim to provide the same efficacy as biological therapies in an oral formulation. Tofacitinib is a small molecule inhibitor that primarily inhibits JAK1 and JAK3, which mediates signaling of the receptors for cytokines L2, 4, 7, 9, 15, and 21, as well as infragamma and L6. It has been shown in randomized placebo-controlled clinical trials to improve the signs and symptoms of RA significantly. Tofacitinib can be used as monotherapy or in combination with MTX. Major adverse events include liver injury, neutropenia, increased cholesterol levels, and elevation in serum creatinine. It is also associated with an increased risk of infections. As well as medication. Next, we see there are some other therapies. All patients should receive a prescription for exercise and physical activity. Dynamic strength training, community-based comprehensive physical therapy, and physical activity coaching have all been shown to improve muscle strength and perceived health status. Foot orthotics for painful valgus deformity decrease foot pain and resulting disability and functional limitations. Judicious use of wrist splints can also decrease pain. However, their benefits may be offset by decreased dexterity and a variable effect on grip strength. After the failure of medication therapy, surgical procedures may improve pain and disability in RA. For leg joints, total joint arthroplasty is an option for advanced joint disease. MCP arthroplasty is generally taken in patients with severe decreased arc of motion, marked flexation, contractures, MCP joint pain with radiographic abnormalities, and severe ulnar drift. Arthrodesis and total wrist arthroplasty are reserved for patients with severe disease who have substantial pain and functional impairment. These two procedures appear to have equal efficacy in terms of pain control and patient satisfaction. At last, let's see the prognosis of RA. Disability shows gradual worsening over time in the face of poorly controlled disease activity and disease progression. It may result from both a disease activity-related component and a joint damage-related component. Early in the course of disease, the extent of joint inflammation is the primary determinant of disability, while in the later stages of disease, the amount of joint damage is the dominant contributing factor. The overall mortality rate in RA is 2 times greater than the general population, and ischemic heart disease is the most common cause of death, followed by infection. Median life expectancy is shortened by an average of 7 years for men and 3 years for women compared to control populations. Patients at higher risk for shortened survival are those with systemic atrial articular involvement, low functional capacity, low socio-economic status, low education, and chronic prednisone use. In summary, improved understanding of the pathogenesis of RA and its treatment has dramatically revolutionized the management of this disease. The therapeutic regimens for RA are becoming increasingly complex with the rapidly expanding therapeutic ways. Research will contribute to search for new therapies with superior efficacy and safety profiles, and investigate treatment strategies that can bring the disease under control more rapidly and nearer to remission. That is all for today. Well, thank you very much.